Good evening. Welcome to the MyCP webinar series. My name is Paul Gross, and I'll be your host this evening. Really exciting. We do a lot about talking about our research efforts as they're started and what their intentions are. This is one that we started less than a year ago, and I'm really excited that we're going to be sharing results of this study of priorities in adult CP research with 4 great speakers that have also been the co-PIs on this effort to gather this information. So the agenda for this evening is I'm going to do an introduction to the CP Research Network, turn it over to Jocelyn Cohen, who will talk briefly about the CP Alliance Research Foundation, and then we'll go into the discussion of priorities in adult CP research. So I've taken to talking a little bit about the history of how the CP Research Network was founded, like why was it created? So there was a National Institutes of Health meeting back in 2014 that came up with several big priorities, one of which was to establish a national registry so that we could sort of track the occurrence and the interventions and accelerate research. A second was the need for more comparative effectiveness research to be able to compare interventions. This diagram below is from a publication by Iona Novak out of Australia from CP Alliance in Australia that shows the level of evidence and the impact of a very wide range of interventions for CP. And you can see there are a ton. And what the meeting identified was the need to compare them so people could figure out what is best for them. Also, the study of adults. So we very often, if you look, a lot of the research that's funded for CP is about kids. And there's roughly, if there are 1 million people in the United States with CP, there are roughly 200,000 kids with CP. That means there are 800,000 adults with CP. So rough numbers, but that gives you an idea of sort of ratios and orders of magnitude. The fourth was to develop a research agenda for basic and translational research. So not just what happens in the clinic or the hospital, but like the basic mechanisms and how to make those discoveries improve care. And then to bring more young investigators into the field. And then finally, to create a closer connection between patients and families and investigators. And those things were laid out at the end of the meeting, and a bunch of us went into task forces to try to move these forward. I was working on a national registry. Mary Gannotti was working on the study of adults, and we really founded the CP Research Network for the purpose of optimizing the lifelong health and wellness of people with CP and their families through high quality research, through education, and through community programs. And so this is the group coming together for our first patient-centered research agenda called Research CP in Chicago in 2017. And that we were really founded to do the things that were described coming out of that NIH meeting. And so we have 4 pillars to what we do. We do research and quality work, and we gather every year. We gather twice a month via Zoom, and we gather every year in person twice a year, but we do a big meeting in April or May every year. And that's a group of us in 2019 in Michigan with Ed Hurvitz, who I hope has showed up in the background, but I will worry about that in a moment. We've got a broad array of educational materials and some new ones coming out, like a dystonia toolkit coming out later this month. We do a lot to engage all of you in the community, as this study demonstrates. It was very focused on community engagement. And then we have health and well-being programs that we focus on. So our vision is that by engaging you as the community and a very large number of health systems, we can create a learning health network. And what a learning health network is, by definition, is something that uses the data that comes from the care of people to improve their outcomes through improving treatments. So our learning health system for cerebral palsy allows us to collectively focus the research on people with CP and the health issues that you have all prioritized through this most recent priority process and through the 2 other ones that we've done to date. And so the goal is to learn about that lived experience and then measure whether or not we are improving the healthcare process and improving outcomes as a function of that. So that's really the vision of what the network does. We've had many milestones since we were founded in 2015. On the education front, we launched the CP Toolkit, which has been served to a large number of families as they get a diagnosis. We've released a well-being guide and translated the toolkit, and now this month we're releasing the dystonia. Looks like I have a spelling error, but I'll go and fix that later. Dystonia and CP Toolkit. And then we have web personalization for all of the information that's on our website. And then we do monthly webinars like this to talk about our research projects. On the research front, we did the first item that came out of that NIH meeting. We launched a registry that we have 2 actually in the clinical registry, which is formed out of that data from hospitals, has over 10,000 patients in it, and then a community registry with over 2,000 patients in it. We published that patient-centered research agenda called Research CP based on that work with the community. And we've gone on to get significant funding milestones, and we've partnered with CPARF as the largest private funder of CP research in the US. We also do quality improvement initiatives, which are just another way to change outcomes. But rather than generating evidence, it's a way of improving processes through checklists like checklist medicine. And we're very academic in our focus. We want to publish the results of our work. So we've had 16 publications, lots of academic presentations, and a lot more manuscripts to come. And what we can do now that we have this very large registry is do secondary analyses of this registry so we can actually learn things directly from the registry. And that registry and those analyses really help us pursue grants with public funders like NIH and the Patient-Centered Outcomes Research Institute. And then on the wellness front, we've partnered with the National Center for Health, Physical Activity, and Disability to offer the mentor program to people in the CP community. And then we're working on developing pediatric programs. So just quickly on what registries are, I'm going to take a data point, the gross motor function classification system, which has 5 levels and describes how people move around in the community. You can see the distribution that is in our registry. That's in our clinical registry where we gather data from people coming into hospitals. And you can see the distribution of ages. And so you can see about 25% of our registry are adults, because many of our hospitals are pediatric in focus. If I compare this to the community registry, which gathers information from you on your computer or on your cell phone through a series of surveys, you see a very different distribution of gross motor function classification system and a real leaning towards adults in terms of the age of people. And this is the bias of the web, where many of you are out there advocating for yourselves, looking for information and being willing to contribute your information to move research forward. So the network is now up to 34 centers across North America. The green pins are sites that are collecting data actively in the registry. The yellow pins are working on our technology infrastructure. The blue pins are sites that have raised their hand, say we want to join the network, but they have not signed our agreement yet. Red pin is a site that's still working on some of the compliance. And then the green circles indicate which sites are lifespan centers. They treat kids and adults and therefore contribute to the data in our adult research studies. And then the orange one is our data coordinating center, where our registries are stored at the University of Pittsburgh. So our goal is to stimulate research. So we set a patient-centered research agenda. We build infrastructure, registries, the network, the data coordinating center, really to help investigators get funding for studies. We try to balance between generating evidence, which takes a lot more time, and improving care, which is the QI work. And we can use our registry as part of that learning health system to monitor whether or not we're improving health outcomes. So I'm going to run an animation real quickly to show you the life of the network and the studies that we've developed. So there's a little bit of a legend at the bottom. You're going to see a bunch of sort of off-white things that those are studies focused on children. The ones that are that sort of chartreuse color are ones focused on adults, and ones in gray are focused on people across the lifespan. So I'm just going to let this go, and then it's going to have a timeline across the top and show you when we implemented these studies over years. And I will note that green is quality improvement, regardless of the audience it's focused on. So as you can see, we have a lot of work going on in the network. A lot of it addresses the needs of kids, and a lot of it addresses the needs of adults. And that's really a very good segue into tonight's topic. So the unique value of the network is that it provides this sustained platform for both research and improving care, and it enables the study of long-term outcomes in people with CP, and it is core to implementing a learning health network. So with that, I'm really excited to turn it over to our speakers this evening. I'm going to turn it over first to Jocelyn Cohen, who's the Vice President of Education at CP Alliance Research Foundation, and she is one of the co-PIs of this study. I'll let her introduce the rest of the team. So take it away, Jocelyn. Do you need me to? Probably should stop sharing.
You should keep that up so I get everyone's titles right.
Okay, great.
Thank you so much for the kind introduction. And as Paul mentioned, everyone, I'm Jocelyn Cohen. I'm Vice President of Education at Cerebral Palsy Alliance Research Foundation, or CPARF for short. Before I tell you a bit more about CPARF and why this research project matters so much to me, I'll share a visual description of myself for additional accessibility. I'm a white woman with dark brown, shoulder-length hair that's down and brown eyes. I'm wearing large teal glasses and a forest green mock turtleneck. There's a CPARF-related background behind me that has white and different hues of green. Sometimes I might look like my eyes are looking away from the screen or like they're rolling, but that's part of my cerebral palsy. CPARF funds US-based research to change what's possible for people with cerebral palsy, implements proven science, empowers people through education, and advances technology benefiting all disabled people worldwide. On the research side, we currently fund an array of projects that address cerebral palsy in all ages and stages of life. CPARF-funded projects and fellowships focus on adulthood, chronic pain, technology, early detection and early intervention, regenerative medicine, and genomics. The discoveries that researchers make today will make a difference for millions of people with cerebral palsy soon and for generations to come. And CPARF's accelerator grant within the CP Research Network funded the important project we're about to discuss with a team that I'm proud to be a part of. So I'll introduce them a little bit here and then tell you a little bit more. So we have Dr. Cristina Sarmiento. She's the principal investigator of the study, and she's the assistant professor of physical medicine and rehabilitation at University of Colorado. We have Dr. Mary Gannotti, who's also a physical therapist, professor of physical therapy at University of Hartford, and the co-chair of the CP Research Network Adult Study Group. And we have Dr. Ed Hurvitz, who's professor and past chair of the Physical Medicine and Rehabilitation Group at University of Michigan, and he is the co-chair of CP Research Network Adult Study Group. So lots of qualified people here who care a ton about adults with CP. And as an adult with CP, I was shocked and angry when I started experiencing unexpected changes in my 30s. Turns out that these changes, no matter when they occur, are common for folks with cerebral palsy at an earlier age. And that kept me wondering, what else am I missing? What else don't I know? What else is common and needs attention? I know I'm not the only one that has these questions, and I know that prioritizing research will play a crucial role in answering them. That's why it's meant so much to me to work on this project. And to kick off the discussion of our work, I'm going to pass the mic to Dr. Cristina Sarmiento.
Thank you so much, Jocelyn. All right, I'm going to share my screen here. All right, so hopefully you're seeing my PowerPoint in the correct view.
We are.
Great. Sorry, I was having some troubles loading.
you need a backup solution, Christina? Nope, there you
Am I
go.
frozen?
No, you're good. You're not frozen.
Okay.
I just didn't know if you needed
Okay.
to mail it to one of us or if you had a backup, if you had a problem.
Okay. Oh, now I went through all the clicks that I was doing. Okay, so this is just a brief overview of what we'll talk about. So we're going to describe our project and give an overview of the different potential research areas that we explored throughout the course of the project. And then we're going to share our results as well as next steps, and then hopefully have some time for discussion and questions. We already went over the investigator team, so I'm going to skip this slide. Thanks for the great introductions, Jocelyn. So a little bit of background. So as Paul was telling us, in 2018, CPRN published its patient-centered research agenda, and that found that the highest priority for the CP research agenda was treatment of pain, functional decline, and fatigue in adulthood. And then in 2019, CPRN launched its community registry, which, as we learned, collects patient-reported data on function, pain, and quality of life. But the challenge is that the current population of the registry doesn't reflect the diversity of the CP population. We're going to give you a little bit more data about this, but that's just a brief background of what inspired this study. Additionally, Dr. Ed Hurvitz's group at University of Michigan has been studying aging in adults with CP. And through this research, we've learned that kidney disease, bone health, and primary and preventive care are major areas of concern when it comes to the health of adults with CP. However, the challenge is, now that we know that these issues exist, we now need a multi-site research program to address these identified issues. So that led to this study, which has the goal of advancing research about adults with CP. We wanted to use the CPRN research infrastructure to gather input and priorities from stakeholders, with the long-term goal being to develop this multi-center research program that's focused on adults and aging with CP. And we really wanted the research agenda to be co-created by consumers, clinicians, researchers, and community leaders. So I'm going to go through the methods quickly of our research study so that we can get to the results, but it was a qualitative research study. So we conducted focus groups to gather data and hold conversations with people in these various stakeholder groups. Our first aim was to conduct focus groups with individuals with CP as well as caregivers. Our second aim was to then conduct focus groups with clinical investigators that focus on adults and aging with CP. And finally, our third aim was to conduct focus groups with community leaders and advocates in the CP and disability spaces. Now, in these focus groups, we reviewed some of the background evidence that informed and inspired this research study, and we talked about 4 topics in particular. We talked about bone health, kidney health, primary care and preventive screening, as well as the CPRN community registry. So we're going to give just a little bit of information about each of these so that you guys also have the context and the focus group participants had. And Dr. Ed Hurvitz is going to talk to us about fractures in cerebral palsy.
Hi, everybody. Sorry, just taking a minute to get a little more organized. Okay, great. Okay, good. Thanks, everybody, for coming today. We're very excited to talk about these topics. So, in adults with cerebral palsy, fractures are very common. Now, fractures are very common in cerebral palsy throughout the lifespan. So, what you see here are graphs for women and men, boys and girls, and women and men. And you see that the dark line represents people with cerebral palsy, and how often they have fractures is always greater than the light line of people who don't have cerebral palsy. With women, it goes up when they get into the menopausal years in both groups. What really surprised us is that with men, it also went up very high as they got older. And you see, even as they get into their late 40s, that numbers gets very, very high. And of course, with men without cerebral palsy, it just stays the same. So this is a very common problem, and it represents quite an impact on people's life when they get a fracture. Next slide, please. Christina, are you driving the slide? Yes. Okay, thanks.
Oh, yeah,
So,
sorry, it's going slow.
okay. All right. So what we found with our research, this is research led by Dr. Dan Whitney, is that fractures lead to illness and even early death. What we found is that there are several things we could think about to prevent fractures, but when fractures occur, there's all of these problems that occur, including loss of function and independence, inflammation, heart disease, muscle wasting, many other things that happen, respiratory disease, things that we have found in our studies that happen to people with cerebral palsy more commonly than adults who don't have cerebral palsy after they have a fracture, which leads to greater, the words we use are morbidity, which means illness and not being able to move around and having pain, and mortality, which means dying. So we can improve and even save lives if we address bone health and do better screening and treatment in adults. Next slide, please. So we want to take better care for bones. Well, how do we do that? Well, one thing is making sure that people get more bone scans, which we call DEXA scans. These are like X-ray scans that look at how dense the bones are, basically how hard the bones are. They also look at your body fat and muscle mass, so we understand how your body is put together. This is something that is generally only done in people after they have a fracture, but we think it should be done more often in people with cerebral palsy before they get a fracture to see what we need to do to prevent fractures. And then if the fracture occurs, we have done some studies that show that physical and occupational therapy after a fracture actually can be life prolonging. It increases mobility. OT can make the environment safer. So absence of therapy can probably leads to less participation, less mobility, and higher risk of disease. So next slide, please. Christina, were we going to talk about some of the results of the bone studies first, or are we going to just run through the? I'll just go with the slides. Okay, so we also were looking at detecting and treating kidney disease in adults with cerebral palsy. Next slide, please. So chronic kidney disease, and again, some work led in our team by Dr. Whitney, is a problem in cerebral palsy, more so than adults who don't have cerebral palsy. What do the kidneys do? So the kidneys in your body clean toxins from your blood. They regulate the amount of fluids in your body. Everybody knows the kidneys help you get rid of fluids when you have too many fluids. Adults with cerebral palsy have an increased risk of kidney disease. This is most likely related to the fact that adults with cerebral palsy have a higher risk of hypertension, likely relates to the fact that they're less active and they tend to have more body fat. It's very common in adults with cerebral palsy of hypertension. So it can lead to needing dialysis and need for a transplant. Next slide, please. So what we have also found is that decreased muscle mass can lead to misdiagnosis. Doctors measure your kidney by measuring something in your blood called creatinine. I want to point out this is not creatine, the stuff that people take as a supplement. This is creatinine. It's something that comes from muscles. If a person has low creatinine, the kidneys are working well. If they have higher creatinine, that can mean kidney disease. Well, we see muscles over here in the image. A is someone with cerebral palsy. D is someone the same age who does not have cerebral palsy. People with cerebral palsy have much lower muscle mass. If a person has low muscle mass, then in general, they'll have less creatinine. If they have less creatinine, then there's a lower amount on the creatinine on the blood tests. So even if the kidneys are failing, it'll come out and read in the normal ranges that we have for the whole population. So doctors can very often miss kidney disease in people with cerebral palsy. Next slide, please. So a faster diagnosis of kidney disease will lead to better outcomes. Early kidney disease should lead to increasing treatment of hypertension, changes in diet, things that you can do to help prevent kidney disease or prevent kidney disease from getting worse. So as I mentioned, regular screening does not work. So maybe we need to do is look at those levels in the blood of that chemical creatinine over time and see, even if it's not abnormal, if it's increasing, we should look at that as a problem. And so we should send patients at risk for more advanced screening. For example, what should trigger us sending the patient to see a nephrologist, a kidney doctor? Next slide, please. Okay, and with that, I will turn it back to Cristina.
Thank you, Dr. Hurvitz. Yeah, we're going to talk about these topic areas first, and then we'll come back to the results. So thanks we'll come back to you in a minute. So the third kind of topic area before we talked about the community registry in our focus groups was primary care and preventive screening. And so we know that adults with CP have a higher risk of chronic conditions and a higher risk of having multiple chronic conditions, and higher risk for having an earlier age of onset of these chronic conditions. And so here are some of those chronic conditions that have been shown that adults with CP have a higher risk of, things like diabetes, asthma, high blood pressure, stroke, arthritis, and mental health conditions as well. Earlier detection and treatment of these chronic conditions is beneficial for health. And the place where a lot of this early detection and screening happens is in the primary care clinic. And so comprehensive primary care and preventive screening can help to identify these chronic conditions earlier and initiate treatment or evaluation. And there are standardized guidelines for preventive services based on a person's age, their sex, and other risk factors. These are put out by groups like the U.S. Preventive Services Task Force and the Centers for Medicare and Medicaid Services, but they're just for the general population overall. And so what is included in this preventive care? So this includes things like medical tests that help to identify conditions earlier when they're easier to treat, things like colonoscopies and mammograms. It also includes services to prevent diseases like flu shots and dental cleanings. And preventive care also includes education and counseling on things like smoking, drinking, diet, weight, and exercise. However, prior research has shown that many adults with disabilities receive lower rates of many of these preventive screenings, despite having higher risk of many of the chronic conditions. And so then we also, in our focus group, shared some of the background information on the community registry, so our adult surveys on function and pain. And so we'll just kind of go over briefly to, why the community registry, what we've done and what we've found so far, what we're doing now, and then what we want to do in the future. So why the patient-reported registry? So we've shared a little bit of that information already, but the patient-reported registry can provide information on symptom burden and quality of life, and similar registries have been used in other conditions to collect information about patient experiences and best practices. And then these data can help inform things like policy, programming, research, and clinical care. So they're a great way to collect a relatively large amount of data in a relatively short amount of time from the community. And so what have we done so far? So starting with Research CP that we talked about already, we identified priorities of functional changes and pain, created that online community and platform that Paul talked with us about, so MyCP. We launched the registry and had a social media outreach, and we published an initial report of the findings, which gave us some really interesting results, but had a biased sample, which we'll talk a little bit more about. So the community registry, just as another background piece of information, has kind of two separate information types. So there's cross-sectional data, which is the base set of information, one-time questions that get asked to everybody that takes the registry. So it gives us information from a person in one snapshot of time. And then we also collect longitudinal data. So a core set of the surveys get sent out to people who are in the registry each year so that we can hopefully understand changes over time. And so just this, we don't have to go over in detail the slide, but this just shows you how much information we're collecting in the registry. So we're getting demographic and clinical information. We have several surveys on function, well-being, stigma, as well as several additional surveys for those people that are experiencing chronic pain. And so this shows you a little bit about the original participants in the community registry. And it's great, you know, we have over 260 people who did our functional surveys and almost 150 doing the chronic pain. But this is where that bias sample comes out. So you can see we are relatively underrepresenting males or men, both younger and older age populations. We are underrepresenting non-white people and people that are Hispanic as well. And so this lack of diversity in the people that are providing information to the registry makes it so that the results and the things that we find and learn from the registry aren't necessarily generalizable to the whole population of adults with CP, because they don't match, the demographics don't match. So we're not collecting data on a representative sample. What we have found is that we see high rates of functional change. So this graph here on the left in yellow is showing us rates of gross motor decline. So declines in a person's mobility with age. And so we saw high rates of that for a variety of reasons detailed here, things like pain, fatigue, changes in strength, or changes in their muscle tone or spasticity. And we also saw that these functional changes with the decline increased by age. So older age groups reported more commonly these declines in function. This figure of a person here too is showing us where people that had chronic pain experienced their chronic pain. So you can see high rates of chronic pain in the low back, as well as the joints of the legs. And for a lot of people, this pain is not being adequately managed. So a lot of people rated their pain as either worse or the same that it was a year previously, and that it's not being adequately treated. And so we did another burst of social media and internet recruitment, partnering with some other organizations to try to get more people to participate in the registry, particularly in those underrepresented groups. And you can see here we were able to recruit more men, a little bit more people that had lower levels of functional mobility and who were non-ambulatory, but we still have work to do. And so we need more diverse enrollees. This was the issue that we went into this current study with. And so what are other enrollment strategies that we can use to try to improve the recruitment and enrollment? So hopefully that helped give a little bit of the context of what type of information we were giving to participants in our focus groups. And now we're going to share with you the information that we got from our participants in our focus group. So our current study's results. So this is showing you kind of who participated in our focus group. So these are the people that participated in our lived experience focus group. So this group was majority adults with CP. We had one caregiver participate. We also had about even male and female gender participate. The participants were majority white, but we did recruit from a few other racial backgrounds, and participants were also majority not Hispanic. We did succeed in recruiting several participants from rural backgrounds and communities, which was helpful to make sure we captured that perspective. And we did get a fairly good variety or spread of the gross motor function classification system level. If you think about it, like levels 1 through 3 refer to people that are predominantly ambulatory or walk either with or without the use of assistive devices, and 4 and 5 are predominantly non-ambulatory or use wheelchairs. And so when we kind of think about that spread, we did recruit participants kind of from both sides of this scale. This is our group of people who were clinical investigators that participated. And so things that were important to us in this group were trying to get participants from a broad variety of professions. So not just physicians, and we were able to include some therapists and one predominantly researcher as well. We had a pretty good spread of clinical specialties. So that was very reassuring to capture those different perspectives. About 50% of the clinical investigators were based in the Midwest, though we're spread across the country. And unfortunately, we did not capture any clinical investigators from rural communities, which kind of fits with the the tendency for clinical investigators to be focused at larger academic medical centers. And then this is the characteristics or demographics of the people that participated in our community leader group. And so for this group, we wanted to enroll participants that represented a variety of community organizations. And we did have 6 different community organizations represented, from those focusing specifically on CP to those focusing more generally on disability, as well as one participant whose organization focused on intellectual and developmental disability. 6, yep. And so majority, or not majority, but a fair amount of participants from this group were based in the Northeast. And again, unfortunately did not capture anyone from a rural community. So in these focus groups, we asked participants among those 3 medical areas that we presented: kidney health, bone health, and preventive care, what or how important they felt that these topics were to them. So we asked them to take a poll and rank the topics on a scale of 0 to 5, so 0 being not important at all, and then 5 being very important. And so you can see here in our adults with CP group and our clinical investigators group, and the top one in orange is bone health, the middle one in blue is kidney health, and the bottom in green is preventive care. So all 3 of these topics were very important across the focus groups and across the different topics. However, then we made it a little bit harder, and we asked people to rank these areas in terms of priority. So 1, 2, and 3 from highest to lowest priority. And you can see here that most participants ranked preventive care as the highest priority topic area. Bone health was pretty close behind, and then kidney health was felt to be the 3rd priority. Some of the overarching themes or kind of messages that we learned from our focus groups were focused on patient and provider knowledge gaps. That was our first theme that we identified. So participants told us that providers are unaware of and uncomfortable with CP care. And when we talked about the risks of things like bone health and kidney disease, many participants were learning about these risks for the first time. And out of this came the need to educate providers as well as adults with CP so that they can be advocates in their own care when they're faced with a provider who's unfamiliar with CP. So this was a great quote from a participant. I just think most people feel like CP is just a childhood thing. It's not. It's a lifelong condition, and the lack of providers in the adult world to take care of us and to really know and understand what we're going through on a day-to-day basis is really, really frustrating. How are we supposed to know to advocate for ourselves, not just as an adult getting older in age, but as an adult with CP who are now at higher risk for all of these other things? The second theme that we took away was the need for a precision medicine approach for adult CP care. So this came out in a few different ways. So one was the goal to have CP specific care guidelines. So like those preventive care guidelines I shared with you that the U.S. Preventive Services Task Force creates, how can we have that, but for CP? And more broadly, how can we take into account a person's risk factors? So their functional level, their age, their medical comorbidities, so that we know who is exactly at highest risk for these chronic conditions, and then how do we appropriately screen, diagnose, and then treat different people differently. And so this participant quote was an adult with CP who said, I would also add, and it's not just screening tools, but what is an appropriate baseline creatinine? And what would be an appropriate amount of increase and or decrease? It could also be different for different GM-FCS levels. We don't necessarily know that yet. I think that would be an interesting question to look into. So this participant was particularly giving an example of a precision medicine approach when screening for kidney disease. The last overarching theme that we took away was the need to address ableism. And so ableism or discrimination against persons with disabilities is a barrier to care. Some specific examples that people brought up were communication impairments that really impact patient-provider relationships, as well as ableist assumptions by providers, especially regarding things like sexual activity and reproductive health. And there really was an urgent need to address this. And one example of a way to hopefully address this is through health profession training. So as we're training doctors, nurse practitioners, therapists, how can we combat ableism early on? So this participant, who is a community leader, said, then there's some practitioners that put up barriers saying that, well, this person doesn't need this preventive care because they're not going to childbear, or they don't have sex, those kinds of things. I think part of it is dispelling those. A lot of it is dispelling those ableist attitudes. So those were the overarching things we took away that kind of cut across all those topic areas. We'll share a little bit more detail about some of the specific things that we learned about our various topic areas. So I'll pass it back to Dr. Hurvitz for these next couple slides.
Thank you, Dr. Sarmiento. Some of the more specific things we were told about bone health. Many adults have personal experience with cerebral palsy, which wasn't surprising because of the high amount of people that have fractures. The clinicians that we spoke to found it very relevant to their practice. They see a lot of fractures, and the community leaders felt the issue was important to themselves and to their communities. The providers were unaware of the bone health risks, and they weren't able to really provide guidance or lead screening and treatment decisions because there just isn't enough information out there. I just put something in the chat about osteoporosis medications. It was a great question, and as I said in the chat, it sounds like a great idea, but we just don't know if it really works and when we should do it. A lot of study has to be done. Here's a quote from one of the participants. They said they have diffuse osteopenia and nobody wants to address it, as well as a few other things nobody wants to address either. They sort of left here knowing that your health's going down the tank and not much you can do. It's my frustration. Next slide, please. As far as kidney health, it was new information for many adults with cerebral palsy. They weren't aware of this at all, and they felt there was a need to increase community and provider awareness. There were several adults with cerebral palsy who had personal experience with the kidney issues. Much of it was kidney stones, which is different than kidney failure, but there is some relationship. The clinicians said they saw issues with bladder functions frequently, perhaps less with kidneys, but bladder function. But again, bladder issues can contribute to some of the kidney problems. They see urine retention and infections. And they noted one of the things that came out that was very interesting is people told us about social and environmental factors. For example, when they're out in public, restrooms may not be accessible and they need assistance to use the restroom. So what people do is they don't drink a lot. They don't drink enough. They become dehydrated and they hold urine. All those things can be bad for the whole kidney and urinary function. So one of our participants said they completely agree about the underhydration. They're only going to change the diaper twice a day, and so they keep them dehydrated. That decade after decade dehydration probably contributes, and I think that's probably very likely. Next slide, please. Okay, Dr. Sarmiento.
Thank you. And then related to preventive care, so the issues and barriers to preventive care were relevant really across the focus groups. And something that came up several times was that this is particularly true for women's health, thinking about preventive screening, things like mammograms and pap smears. Another issue that came up was healthcare system accessibility. So, it's all great and good if your provider orders a mammogram, but what if when you get there, it's not even accessible to you as a wheelchair user? Participants also shared that the transition to adulthood is a particularly challenging time. You're changing providers, you're changing services, and then there's also this view of CP as a static childhood condition, and adult providers don't get the unique needs of adults with CP. And so that need to educate the CP community, in addition to healthcare providers, came out a lot in this preventive care sphere as well, so that we can both improve the knowledge and awareness of clinicians, as well as empower the community to be advocates for their care. So this quote here was from the caregiver of a young man with CP, and she said, when we see our primary care provider, it's only because he needs a vaccine or he has an infection or whatnot. I'm not seeing any preventative care. So now we're going to turn to the community registry a little bit. So we also asked a couple of our focus group participants how important they thought it was to collect patient-reported outcomes through a registry. Again, kind of from a 0 to 5 scale, where 0 is not important and 5 was very important. And so you can see Most participants in our clinical investigator group felt that it was important or extremely important, and everybody in our community group thought it was important or extremely important to continue this effort to collect patient-reported registry data. So people shared with us their views and perspectives on participating in the registry. So what we learned is that it's really important for us to appropriately communicate the motivators or the reasons to participate in the registry. So this included things like being able to educate oneself on important issues, understand one's own health, as well as contribute to scientific knowledge in the broader community. Several participants shared with us that they trusted CPRN as a source for information and research, and so this could hopefully be a facilitator to participating in the registry. However, we also need to ensure accessibility of the registry. So this included suggestions like providing more visual information, enhancing social media recruitment. People shared that it was hard or challenging to access the surveys. There were a lot of steps involved in terms of signing up for MyCP, logging into the portal, and then taking the surveys. And then we also need to ensure that our surveys are accessible with things like screen readers and head pointers. Another opportunity to improve participation and diversity in the registry is to allow for proxy responses. So right now, people can only participate in the registry if they're able to consent to participate themselves. But for people that have much more severe disability, they might rely on a caregiver or family member or supporter to respond on their behalf. And right now, the registry does not capture those voices. So this quote comes from an adult with CP who participated, and they shared, "I just want to be able to help. Any information that I can give on to somebody else. I don't even know if I filled out that form or not. Like I said, I learned a lot today, but it's more about giving back what I can to do to help. Probably in my younger years, I didn't think about this or didn't even want to think about this. Now it's more, especially when it hits home. You see somebody and you say, man, they're probably going through the same thing that I am. It's more about anything that I can do to give back to somebody else." Participants in our focus groups also shared suggested recruitment strategies for the registry. So these included things like minimizing the burden of survey. I think we all experience survey burnout, as well as being more accessible and visible on social media. So things like tweets and leveraging the platforms of some social media influencers that participated in our focus group. We also need to optimize our collaboration with our clinical sites. So there are some challenges to this, but how can we actively recruit participants into the registry in the clinic setting? Or at the very least, can we give QR codes to the MyCP in after visit summaries from clinic visits, have flyers in waiting rooms? How can we leverage those clinical connections that the CP Research Network has? Additionally, how can we collaborate better with community organizations? So we got lots of great suggestions from participants about how to recruit from the disability space more broadly, target both younger adults through like high schools and universities, older adults through community and senior centers, and those with more severe disabilities like people associated with independent or supported care facilities. So this participant, who is a community leader, gave us a quote about the survey burden. So we are working pretty aggressively to reduce barriers. We saw that a lot on our own folks locally. We were getting a few questions in or partially through a survey and then just not completing them. We've ended up making them more modular, making them shorter, making various options for shorter surveys. And so just to wrap up here, hopefully with a few minutes left for any questions or thoughts, this study is, like all studies, not without its limitations. So we recruited participants from CP and disability-focused networks. And so a lot of our participants are active in and connected with the CP community already. And so their perspectives and their thoughts, they may differ from people that are less well connected to these networks. Additionally, we really prioritized and sought to amplify the voices of adults with CP, but we did only end up with one caregiver participant. And so it's hard to say, would a larger group of caregivers of people with much more severe disability, would they have any different perspectives or different thoughts? And so just to conclude, Participants in our research study, they identified preventive care as the top research priority among those presented. Knowledge gaps, the desire for a precision medicine approach, and the impact of ableism impacted all of the research areas we talked about. And to optimize recruitment in the community registry, we need to clearly communicate its benefits, minimize barriers to participation, and leverage both our clinical and community collaborations. And so our next steps in this line of research, so we are seeking to develop interventions to facilitate the primary care and preventive care interactions for adults with CP, and seeking to continue to engage stakeholders in the process. Participants also felt that bone health was a significant issue. And so really the kind of next important step in there is to identify who is most at risk for fractures and low bone mineral density, and how can we use that knowledge of who's most at risk to then guide appropriate screening measures. And we have so many new great ideas for new solutions and strategies to optimize community registry enrollment and diversity, including this QR code here, which will take you to MyCP to sign up, and then you can participate in the registry. And so that is it. Thank you for listening. And we saved a couple minutes for questions or thoughts.
Yeah, thank you very much, Dr. Sarmiento, and Dr. Hurvitz, and Jocelyn Cohen, and Dr. Gannotti. Appreciate it all. We obviously are on a debate night, and I think it's going to be tough. I don't know that I can ask people to stay late, but questions? Maybe raise a hand. There's one in the.
Suggest really quickly is
yeah, go ahead.
If people have questions and they want to ask them, there's a way to get them to you, Paul, at CPRN, and then we can make joint content about it and answer those questions like on social channels, so that people can have like ample time to think about and react to this, and then we can make sure that we answer those questions for a wider group. I see Duncan raise his hand though, so I'm going to mute myself.
Duncan, you have 1 minute.
We could have a follow-up CP conversation about this, Jocelyn.
Yeah,
You know,
And we can also have a discussion on MyCP, which would be a great place to have it. But go ahead, Duncan.
one of the issues that Cristina raised was a concern of folks about accessibility to diagnostic equipment, particularly mammography for women. Please note that this month, 32 years after the first ADA guidelines were issued, the Access Board has finally issued its guidance for diagnostic health equipment and examination room. So if anyone wants to look at that, it is on the U.S. Access Board website. Their webinar concerning the newly issued guidance on accessible diagnostic and examination equipment.
Great.
Thank you, Duncan. Yes.
Great to see, however long it took. All right, I want to thank everyone. I need to be really, like on this evening in particular, be very respectful of everyone's time. Thank you to the presenters and co-PIs on this study. I think it's great work. I put my email in the chat. You can go to MyCP and ask questions. A number of, pretty much so everybody that's here that's participated can answer questions there, and we'll do our best to come up with a way to have a little more Q&A on this, at least virtually over the next several weeks. Anyway, thank you all so much.
Thanks, everyone. Have a good night.
Thank you all.